Hi everybody. Today in this slot we're going to be talking about an approach to how to navigate a consultation with a woman coming in for a TOP. These are things that I think are important. Other people might approach it differently. I've often had questions from students in their reflections about the other TOP TUT, about the societal issues around TOPs. Questions saying that they appreciated that, but they still don't know how to deal with a consultation or how a TOP works. So these little videos are to help deal with that. I've got my piece of paper here to remind me so I don't forget anything, and I will put this on the site as well. Okay, basic principles before you start the interview is that you need to have established a rapport, because this can be a sensitive topic to discuss, and there are a lot of societal issues around this topic that might need to be explored. So you need a rapport, the person needs to know your name, and you need to be friendly and just nice. You need to be alert to body language. I know I'm always yammering on about that, but patient body language is so important. You can learn so much about a patient and their circumstances from that. So you need to look out for whether the person is very emotional, which might mean they're feeling ambivalent about the decision, or whether they look depressed or anxious or whatever, because that's a cue to ask about what's going on, and we'll come back to that. And linked to that is that you need to interview the woman alone. Now, how does one accomplish that? So if a woman comes with a partner, you invite them both in, you establish your rapport, you make sure everybody feels heard, and then when it comes time to examine the woman, you ask the partner to leave. And usually they will, because they're not suspicious of anything, but that is then your opportunity to speak to the woman to find out whether this is really what she herself wants. If you're in a situation where there's a minor who's come in with a parent, usually the mother, that can be very difficult. Remember that a TOP can be signed for by anyone older than 12. But often you'll have a parent who's sort of dragged this teenager in and said, you're having an abortion, or I'm kicking you out the house. It can be difficult to ask that parent to leave. But again, if you've established a rapport and you've heard everybody's concerns, and then you ask to be able to examine, often the parent will leave. My advice to you, if there is a minor, especially if you're a male, is to ask for a chaperone when you are alone with that patient. If the parent refuses to leave, you're pretty much screwed, and there's not much you can do about it. Okay, then moving on to, because TOPs are such a societal issue, we know that we need to ask about social circumstances. So who is the person living with? Is she in a relationship? And particularly, what is the nature of that relationship? Because you will remember, okay, we're just going to turn around here and slide down a bit. You will remember this slide, hopefully, from the IPV presentation, where termination of pregnancy is closely related to intimate partner violence, because women lack agency over their own reproductive health. So when a woman is coming to you asking for a termination of pregnancy, you do need to gently explore the nature of the relationship that they are in, because there is a direct link there. Okay, then moving on to the pregnancy itself, you need to know, to try and work out what the gestation of the pregnancy is, obviously, because that's going to determine what kind of TOP you can offer, or even if you can offer a TOP. So last menstrual period, what normally happens at GSH is that a patient will have been scanned, and we will have the gestational age in the paperwork that comes in with the patient. But if you don't have that, you need to try and calculate it based on the last menstrual period. That can be incredibly difficult because of the Depo-Provera induced amenorrhea that we see. And then maybe a woman misses one dose and she falls pregnant, but she was amenorrheic all along. So that's where your clinical examination will be helpful. Very important to determine the circumstances of the pregnancy. We know that pregnancies can result from rape or sexual assault or incest. So if that's the case, then you need to explore that, and that needs to be managed. And also, often it is an issue around family planning, failure of family planning, or issues with access, or any of those things that we've discussed in the other TUT. So you have to gently explore, not in a judgmental way, but you have to explain to the patient that you need to understand how this pregnancy happened so that we can prevent this happening again in future. Okay, then in terms of the pregnancy, it's important to ask whether anybody knows that she is pregnant and whether anybody knows that she intends to have the termination. The reason that that is important is that women who are very isolated with no support during this time are at a higher risk of psychological sequelae. Most women, as Prof. Focus said, most women do not have post-abortion regret. Most women do not have psychological sequelae, like serious long-term issues. But a woman who's very isolated and doing this all on her own does have a higher risk of psychological sequelae and depression afterwards. So that's something you need to find out. And then, look, by the time a woman is sitting in front of you, she probably pretty much already knows that she wants a TOP. But I suppose in order to make the consent really informed, you need to explain what the other options are, which she probably already knows, which is either keep the pregnancy and keep the baby, or keep the pregnancy and give the baby up for adoption. But I don't harp on too long about that because most women really do want the TOP by the time they get to you. Okay, then the next heading is reproductive health. Clearly there has been an episode of unprotected sex, so you need to talk about STIs and HIV. At GSH, most women will come in having just had an HIV test at the clinic, but this woman definitely needs an HIV test today and then to cover the window period in 3 months' time. You need to spend a substantial amount of time talking about family planning options going forward, because clearly there's been a failure somewhere and she wasn't adequately covered, and we'll come back to that when we go through the paperwork. And this is also an opportunity to ask about pap smear screening. So these are young women, many of them will be in the age group who are eligible for pap smear, so you should explore that. Then in gynae history, you need to know the nature of her menstrual cycle, specifically if she has very heavy or severely painful periods. That would preclude the use of the IUCD as a longer-term contraceptive. So that's something that's important to find out when you're making your family planning decisions. And obviously you need to know other relevant medical history that might influence your family planning decision. In terms of obstetrics, you need to know whether, or in fact gynae surgery as well, you need to know whether there's ever been surgery on the uterus, because that might lead to an adherent placenta, which is something that you might need to know when you're making decisions whether someone needs an EVAC or not. So those are just the general principles. Obviously you're going to do the full history, but those are the things that to me are really important in order for you to help this woman in a way that she best needs to be helped. Like I said, medical history is also important, particularly in terms of family planning choice. And then you will examine the patient to determine the height of fundus, or how big you think the uterus is, to help with the dating. If a woman comes in already with a scan, then we don't usually need to do an extensive examination because that information is already there. But if you don't have that information, then you definitely do need to do an examination. Okay, so in the next segment, we're going to look at all the paperwork that has to happen for a TOP to go ahead. We are talking specifically here about second trimester TOPs. So these are patients who are coming to GSH because they are beyond the first trimester and they need a second trimester TOP, or let's put it this way, they're beyond the 9 weeks prior to which a medical TOP could have been offered at the clinic. But all the questions that we've been through in this section so far are relevant to any situation of a woman coming in, no matter what the gestation. But now we're going to move on to specifically second trimester TOPs. Okay, just going to stop the video.